So what about me? Well, I'm an occupational therapist. I was in clinical practice like Geraldine for 15 years. And in that time, I worked a lot in paediatrics, end-of-life care, children with life-limiting conditions. And then I moved into adult services, and before palliative care was really defined and understood, I supported people to live at home who had late-stage MS, motor neuron disease, and muscular dystrophy. And for me as an occupational therapist, it's always been around that importance of home. Home is the space where we would all want to live for all of our life. And place, and how can we use both the environmental design and technology to support people through that pathway towards that very important time in all of our lives, which is death. And so I have James in my life. He's my eldest son. He has Down syndrome. And I know as well with him, there's this high likelihood that dementia will kick in pretty early. So I'm interested to see how I can use technology with him to enable him to live as independently as possible, but also to help future plan for him in his own home space so that he can engage in all of the things that we all like to do in our lives. So there's another motivator that wasn't there whenever I graduated in 1987, now you all know my age, as an OT. And I live in Belfast. I'm a Belfast girl, born and bred, Northern Ireland's my region. And I love Ballycastle. We have a summer home in Ballycastle. Lots of people from Dublin, summer homes in rural areas. And what we do know on this beautiful island of ours is that there is inequity of healthcare provision, inequity of resources around networks, around internet, around hardware, around affordability. So many factors that influence whether we can actually use technology in the way that we've been talking about today. And all of these things fascinate, intrigue, puzzle, and make me want to be involved in a community like this today to try to have these conversations and see if we can influence the policymakers and the funders to help us in the work that, great work that I hear going on. It's just fantastic. So that's my kind of motivation. And there are things that we do know. Technology is pervasive, and we hear about the digital native, these children that are born now. They use technology from the get-go as part of their everyday life. But we do also know that people like me in my 50s, I'm a consumer of healthcare. I take healthcare in a very different way than my parents. I want to be involved in my own health management. I want to be involved in making decisions about my nutrition and my sport to try to keep myself well. And the idea is that people below me and people at school now and people heading in towards nursery school, that they will also have a very different way of thinking about health and thinking about preventative health and self-care strategies. And how will they consume their healthcare, because we do know it is absolutely pervasive. How many of us could live in this everyday world without our iPhones? You kind of feel you need to give it a little hug or a cuddle or a rub every now and again just to check it still loves you as much as you love it. And the software, some of which I can't even keep up with. I've just taken a decision, don't try to do Instagram because you don't get it, and if you do, your children will hate you. So I haven't even opted into that. But this is now routine. At first, when we saw photographs like this, we were shocked. But now it's how people live, how young people live in healthcare. We know there are consequences of this. We know it's having implications in terms of how people connect. We know that some young children are starting to use expressive language later. So there are things that people like us need to think about in the context of society, in the context of ethical use. And then we have technologies that come in a really affordable way, and they cause disruptive innovation. I think back to my early research projects where we got lots of money from the European Commission. God bless them, thank you very much, and I'm dreading Brexit. However, we would work for 3 years in a project, maybe looking at social connectedness and looking at new technologies, and somewhere from California out would come Facebook and bump, pipped at the post, and we still weren't quite ready in our process to bring things through. So how can we look at Amazon, the Alexa, Hive, things that people can go in and buy commercially available, and explore the implementation of those within a person's own home and help guide the use of that for the people that we're thinking about today who have palliative care needs. We know in the literature that there are positive reasons for using technologies. People want to bring their own devices into this space, but they will seek guidance from people like us. How should we use it? Can we do it? If I come up to your clinic, if you are my nurse, how can I use what is available in the general public space as part of my healthcare and support that journey and support my family in their caring role in this journey of palliative care? So for me, as an occupational therapist, and actually just at this stage as a person, as a human being, I'm very person-centred. And I always hold that to my core. And I think as we talk about using technologies, we need to think about, well, how do we really keep the person at the centre? Because we can talk about it and I can roll out these words, but what does that really look like in reality within services? And if we step into the shoes of our service users, do they really feel that they have been at the centre? Or is it still a technology push by somebody who's very excited about the device? So I've spent a lot of my research life working with people who are very excited about technology. My PhD is from computing and engineering. I work with a lot of engineers who love the devices and the things that they create. And great innovators, great ideas, and sometimes they want to really push boundaries that society isn't just quite ready for yet. For example, you'll see some videos in a moment on some of the BCI work. The BCI engineers that I worked with around Europe really cannot understand why we just can't embed the sensors in under the skin. They just don't get that. They think it would be so straightforward if we could just move to that space because they reckon we're going to anyway, so why can't we just do it now? And so the people that I work with are the innovators, and also I try to identify early adopters. I try to identify lead users so that we can work with people who resonate with the challenge of the topic in hand, have some maybe understanding about technology and who are maybe keen to explore it. And I try to bring those people into the research projects that I work within. And I use various research methods, generally engage. This is a sort of very typical approach that I would use, generally engaging in an iterative conversation over the development of devices with the designers, the technologists, the engineer, the computer scientists, and the people that use the technology. And those users of technology vary. Quite often it's the patients, sometimes it's other people as well who are the users of the devices, and not always the person themselves. So in the first instance, in this Back Home project, which was looking at migrating a brain-computer interface from the lab to the home space, we did a lot of work with the therapists. So this is a focus group of physiotherapists, occupational therapists, and speech and language therapists. In Northern Ireland, there's a regional brain injury service, but the therapists felt that once people were discharged from the service and they go back to Fermanagh, they go back to Donegal, or they go back to Derry, that suddenly it's cut, and they felt that they didn't have the opportunity to sustain that rehabilitation and really support somebody maybe back into work or back into mainstream life. So they worked with us to develop online platforms, so that they could both support rehabilitation, schedule visits, have Skype sort of connections and things like that. What we needed to do was help them understand what a brain-computer interface was as well, because you can see the cap on the table. At the far end, at the home end, the person at home was using the brain-computer interface to engage with the system. So these were people at home with high level of disability who were maybe still on some cognitive rehabilitation programs and things like this. Quite quickly we moved from looking at brain-computer interface and a cap that might evoke a response on a computer that the person might control their home environment, to building in multimodal systems, which I kind of, in the background of my head, that was kind of like just throw everything at the system and see what we can get to connect and interact. So AID is a project that just finished last year. And again, this lets you see some of the end user engagement. This is a consultant in rehabilitation medicine, and he's working with our participant. So she's got the BCI cap on, and he's explaining to her how the system is going to work, what's his expectations of her during this, what it might feel like, and what the protocol basically for the experimental scenario is. You can see she's squeezing her hand there as well. So taking time, working with a single user, so moving away from the focus group, working with a single user and letting her test out the system in hand. Just by chance, it's the same user, but this lets you see how In the previous scenario, this user was testing out the brain-computer interface cap, and here she's using an eye tracker technology to test out a robotic arm. So prototype development, innovative products, working with industry and university, and trying to get things to market pretty quickly and funded through the European Commission. And you can see the researchers in the background, so they're observing how it's going, they're checking the protocol out, they're checking the technology, and we're also looking to see what's her experience, and then we did sort of interviews and questionnaires with all of the participants afterwards. And I'm really interested in what's happening in society, and certainly within the north of Ireland we have a few facilities, about 10 facilities, that are technology enriched to provide pervasive homes for people with dementia. And they bring in best informed environmental design and also some creative spaces using technology so that a person can function as independently as possible with support within the facility, but the support is more remote. In that we try to be less intrusive. So these are the sorts of information systems then that appear for staff so that they can keep an eye on what is normal patterns for that person, and alarms and alerts. I mean, it was alluded to earlier about the smart homes, alarms and alerts that go to signify, well, is there something wrong in this particular client's home? As it turned out with this particular client who was spending a lot more time in bed at that time, it was because Wimbledon was on and she was watching Wimbledon. But what triggers do we need, and when do we need to respond? And these are big issues that I think we still need to explore. This work has been ongoing from 2005, and I don't believe that we're actually there yet with answering all of these issues about, well, when do we know when to intervene and what is okay in terms of ethical use of all these technologies. And they're very big questions. Recently, thanks to the HSC R&D Board, and Gail is here today, and Atlantic Philanthropies, we were funded to complete some interviews with some tenants who lived in these facilities. We completed a big evaluation project actually on all of the facilities, and one component was around the interviews with tenants. So these people have dementia, so they're a vulnerable group to start with, and there are obviously issues around communication and helping them communicate and have their voice heard. So we were really challenged as to how we would do this authentically. I hate that word because it's kind of used an awful lot at the minute, but how we could be very genuine in our approach. So pushing our methods a bit further, which is what we find we always have to do. We looked at PPI and public involvement and seeking peer researchers. So we went back into the literature and looked at some work on peer researchers with younger people. And we put out an open call through Twitter and through the internet for older people who were retired, if they would be interested in stepping into our world for a brief period of time and supporting the research directly with the people who have dementia to understand what life was like for them in these facilities. We got a great response. We did a lot of training and preparation, and they supported the information that we got in the previous slide that you saw. In this slide, just to show you that we've used actors. That slide's not going to work, the other videos work, but we've also used actors to help us generate and role play out scenarios of use cases that we will then use with people who have dementia or who have quite enduring issues because of brain injury, to help explain the type of projects and work that we're doing. But ethics and ethical challenges remain an issue. It's very difficult for me when we have 3 layers of ethical approval: the university, the HSC, and then our OREC governing body, all of which are very, very important. And so I arrive and I say, I want to work with people who have dementia or people who have brain injury or people who have learning disability, and I want to explore this technology. And they say, what is it? And I say, oh, I don't know yet because I'm actually helping design it. And they find that really difficult, which I understand. But I think there is a responsibility for us to do some work on ethics and ethical governance in this area. And the other thing I think about is is the technology always an intervention? Because we're being pushed to use empirical research methods all of the time. Sometimes it's not an intervention. People use the technology in many ways. Sometimes I think we change the context of care. And so again, I think we need a bit of a public debate and a conversation to kind of engage and get those people who are pushing the empirical methods maybe to engage a little bit more in what's realistic. We know that there are challenges with technology. This was little Luca on the first slide that you saw, looking at his iPad and his Apple. We know there are issues with technology overload. There are sensory issues. We hear it in the media all of the time. So introducing these technologies into palliative care and into services, we need to be mindful of what are the unintended consequences, and can we capture those and engage people in those conversations around how we manage it. Working in this area for a long period of time, people get very excited about technology. And sometimes I think we have to call it a little bit and say, do you know what? This really isn't anything new. That type of service has been around a long time, or that technology has been around a long time. At the minute, we're just calling it something different. But the evolution of man, it is pervasive. They're part of our everyday technologies, and I think we all as a civil society need to engage in the conversation and try to figure out how we manage these services for the digital natives of the future. Advanced care planning, the technology should be in, and part of that, making decisions about what level of contact and how things can be used. So on our beautiful island of Ireland, we also have to think of Dublin and Belfast, these major cities that have a lot of resources, where it's easier to get the connectivity, where the Wi-Fi works and the 4G is stable. And we need to think of my beautiful Ballycastle and Craggy Island, and how do we look after Father Ted in his old age. Thank you very much.